Good afternoon. We are going to spend some time with the management and evaluation of some selected infectious diseases. And I could think of no better place to start than with influenza. I also want to point out that I am using the same patterning or in concert with your Butera text so that I can provide for you just those nuances, those most important priorities. I will probably integrate some pearls and maybe use other sources at times, but I'll mainly be going by the text for my lectures. So we know influenza is an acute infection of the respiratory tract caused by influenza A or B, and in the past it's been caused by H1N1. But here we're specifically dealing with A and B. The epidemiological issues within influenza tell us that it's a self-limited disease. It's primarily identified and occurs in the winter months. We do know it's highly contagious to all age groups. And the infection rate is highest in children, but the death rate is higher in older adults greater than 65 or those patients with underlying chronic illness or immunosuppression. And because of the contagious nature of the virans, outbreaks do occur. The pathogenesis of influenza is that it is transmitted person to person when that infected person talks, coughs, or sneezes, and that's delivered via respiratory secretions that contain the virus. We can detect virus within 24 hours before symptoms begin. The virus then penetrates the respiratory tract epithelium and it reproduces. This viral replication causes cell death, which releases a large amount of the virus to adjacent cells. And at that time, that creates desquamization of the ciliated epithelium, and acute symptoms will often coincide when this desquamization happens. One of the things interesting about influenza is that the virus evolves, and it evolves each influenza season. We actually call that antigenic drift, and that's why we need a new seasonal vaccine to be created and delivered. Clinically, the presentation for us to keep in mind as providers is incubation period is 1 to 2 days. There's typically an abrupt onset of symptoms, and they kind of hit really hard. You'll see a fever between 100 and 104 within 12 hours. That fever will decline within 2 or 3 days, but the patient will have chills, headache, malaise, myalgia, loss of appetite. Respiratory-wise, the dry cough is the most prominent symptom. There's usually clear nasal discharge, sore throat, but these symptoms are often overshadowed by the systemic symptoms of, as mentioned above. Convalescent phase is 1 to 2 weeks that after the fever has ended. And interestingly enough, some people have a mild illness like a cold. They really don't present like the typical influenza, and but it's still, you have to take in more than the presentation when you are creating those differential diagnoses. Children, elderly, pregnant persons with chronic illness may have experience a rapid worsening in influenza, so don't be hesitant to work them up thoroughly and bring them back for reevaluation. And then just as a matter of information, H1N1 has very similar symptoms as A and B. Generally in clinic, when I see people with positive flu, they appear ill. They look ill. I can hear them coughing while I'm reviewing the EHR outside of the exam room. So interestingly enough, uncomplicated cases of influenza have minimal PE findings despite the symptoms. Generally, these people, their faces are flushed, their eyes are watery, clear watery, and red. They're injected. There may be a fever. Typically, I see a fever with a positive influenza, but not always. And the skin may be hot or moist. Generally, their nares are inflamed. Their pharyngeal, there is pharyngeal erythema. Um, Although it is not, and the exudate are not always common, I do see more injection of that oropharynx when people have the flu, and maybe even a clear postnasal drainage. Cervical nodes tend to be enlarged and tender as they respond to this virus, and the chest exam is usually normal, clear lobes, and pulse ox is typically normal. Diagnostically, preference is nasal or a throat swab. I use nasal swabs in my clinic. Within 12 to 36 hours of onset of symptoms, and that one reason you need to have enough of a viral load, but you also want to think, will this test alter my plan? If it's past 36 hours, you would really behoove you not to offer an antiviral. So we'll talk about that in a minute. Viral culture is still used in some places. It usually takes 2 to 7 days to get back. And then clinical diagnosis in the setting of a confirmed influenza outbreak is very accurate, okay, as pointed out. So maybe you see a client and they don't want the nasal swab or the viral culture. They don't have insurance. They don't want to incur that. They're not going to choose an viral, or it wouldn't be appropriate. And so it's fine and quite appropriate to use clinical diagnoses in the setting of an influenza outbreak as your information to make that diagnosis. So again, it would make sense that the management of influenza A and B is primarily symptomatic. Rest and fluids. We can give something to control pain and fever and aches. Very important, no work or school because of the contagious nature of this disease until they have recovered. The treatment options, there are 4 antivirals approved for treatment. And these are recommended for people at risk to develop complications, so those with severe illness and or hospitalized patients. And Tamiflu is the one that I use the most frequently in primary care clinic, but you can review those. I also go by the CDC resource for selection of antiviral, which I really appreciate. Again, looking at those evidence-based guidelines and our experts to help guide my decision making. So it is most effective to start an antiviral within 48 hours. Greater severity of symptoms by 1 to 2, so it lessens the severity of symptoms by 1 to 2 days. Pretty much after the day 3, it is just flush. It doesn't really make any difference. But I do think it's important to make that decision of prophylactic treatment for those exposed, and you'll have to make that with your clinical reasoning skills of who the patient is in front of you and who are the exposed that within their family or their friends or their occupations. So encourage. Probably the best recommendation is encourage the exposed person to get a vaccination. Only vaccinate with inactivated vaccine if you're using it as prophylaxis, okay? And because if you give an antiviral, then it will negate the effectiveness of that vaccine. So referrals. Primary complication is pulmonary, viral pneumonia, and or a secondary bacterial pneumonia. And these people will need a chest x-ray and probably hospitalization. Just depends on the patient and how closely you can follow them. Patients who do not begin to improve in a few days need to be referred for a much more comprehensive workup. Patients with underlying medical conditions may need to be hospitalized, and keep that in consideration. And anyone rapidly getting worse should be considered for hospitalization. Don't be afraid to bring your patient back, to call your patients to bring them back. And patient education and health promotion. Mortality for influenza is highest in the elderly, so we're going to make a lot of clinical decisions based on that. No, young infants may have different clinical symptoms for influenza. We'll just review those and be aware. You'll go into that in depth in pediatrics. Yearly influenza vaccine is the primary preventive method, and vaccines can be given 6 months and older. And personal hygiene measures, hand washing, covering the mouth and nose for coughing and sneezing, and stay at home when ill and avoiding crowds. Thank you very much for your attention.